Perfect. Thank you, Dr. Ihab. So first of all, just a quick introduction. My name is Nadine Milhem. I am a pharmacist, been a pharmacist in Canada for the past 5 years. I went through the steps like we all did, or you're doing now. Took my OSCE with Dr. Ihab and passed from the first time. So I reached to the level of a pharmacy manager. So I've worked with Rexall, and I'm taking a short break in the meantime. So I started with 𝐤+ recently, and I'm loving it. I'm going to talk a little bit about the MCQ exam, what to expect, what competencies they look for from the pharmacist who is giving the exam, in order to prepare you better, like Dr. Ihab said, for the consequent exam, which is your OSCE. So MCQ, there are multiple choice questions, as you well know. It is all about your competencies, like your clinical competencies, as well as your communication, collaboration, and managerial competencies as well. So it is a computer-based testing. It's usually 4 hours and 20 minutes. Some people finish earlier, depending on how quickly they maneuver the questions and how quickly they go through their exam. It is 200 questions. However, 150 of them are scored and 50 are unscored. Those are for basically they're for PEBC, trying out new questions or trying out different levels that pharmacists have, and so they can pursue different maybe ways of questioning us and questioning our competencies. So like I said, the competencies that PEBC test pharmacists in, first of all, it is about providing care. So it's about clinical care and distribution, and that takes up to 50% for clinical care and 20% of distribution. When we talk about clinical care, we're talking about science. So you need to be very competent in your scientific background, how well you know different areas and medications related to those areas, as well as how well you also relay those types of information. They also look at, like I said, your knowledge and expertise when counseling patients, communication and collaboration with other healthcare professionals, as well as patients, your leadership and stewardship. So how you manage the flow of the pharmacy, how you manage patient questions, conflicts between your colleagues or your team in your pharmacy setting. Professionalism is also a big one. As you know, as pharmacists, it's not just about the science, it's also about how we treat our patients, how we provide them with continuity of care, how well we communicate with other pharmacist colleagues and also other healthcare professionals, whether we're talking about doctors or nurses or their basically circle of care, the patient's circle of care. Next, Dr. Ihab. So how does 𝐤+ do it differently? First of all, you need to know that with MCQ, it is a challenging exam. So it's all about your confidence in the material, your confidence when you get to your exam. We do provide recorded lectures and study handouts, tackling all the topics that are going to be brought up in your MCQ. We do provide case studies and practice questions. We have a huge question bank, question and answer bank. Reference books are there for you to check out, in addition to the lecture notes and the handouts that we provide. There are both live and recorded lectures, so you do get that face-to-face time with your instructor, but also you have time to review all the discussions that happened in class to help you study better. Also, like Dr. Ihab said, we do have a final mock-up. Mock exam, simulating the actual exam. So you'll find a lot of case studies, you'll find tackling different topics, tackling different areas, therapeutic areas and medications. All right, next. We're going to start off with just trying a few case studies. So I'm going to start off with the first one, which is a therapeutic one. I'm going to start reading it. If you guys feel like, answering or adding any comments, please go ahead and do that.
Okay. Can I just add one thing? Even for evaluating people, I know that there are some people who are online, they are still in the evaluating, stage. Be careful that evaluating exam is becoming now a mini MCQ. And I think Nadine and Keisha will highlight that. So if you can try, even, I know that you say, oh, still I have another exam, I'm on the first stage, let me wait. Don't wait. Even now, try try to read the case, listen to Nadine and Keisha, and try your best. You know, you will not lose anything. Sorry for that. Thank you, Nadine.
All right, so starting off with the first case study. So we have Mr. Jonathan Carter. He's 60 years old. He's a retired teacher. He is coming for a routine follow-up. He has a 3-year history of type 2 diabetes mellitus, along with borderline hypertension, dyslipidemia, and peripheral artery disease. He does not smoke. His BMI is 28, and blood pressure is 138/90 millimeter mercury. He is currently on metformin, 1,000 milligrams twice daily. His results are as follows. You've got A1C of 8.5. His LDL cholesterol is elevated at 3.6 millimole per liter, and his HDL cholesterol is borderline low at 1 millimole per liter. His triglycerides or triglyceride level is slightly elevated at 2, and his estimated glomerular filtration rate is 80 milliliter per minute per 1.73 meters squared. Now, so that suggests preserved renal function. Before moving on to the questions, I just want you guys to have like a closer look and try to find the issues here. So he is type 2 diabetic. He's been that way for 3 years. He is borderline hypertensive. He's got dyslipidemia and PAD. Those are all high risk for this patient. His BMI is 28, so he's also overweight. So we need to do some lifestyle modifications there with diet and exercise. Maybe encourage that. His blood pressure is 138/90, which is, according to Diabetes Canada, that is way above the range. It needs to be less than 130/80 for him to be controlled, especially when we're talking about his diabetes history. His LDL cholesterol is elevated, so that increases his risk when it comes to cardiovascular risk, even though his kidney function is good at the moment, but all of this can actually have a bad outcome moving forward. So we can go to the next slide, Dr. Ihab. Okay, so first question is, what is the primary reason for initiating statin therapy in Mr. Carter? A, his HDL-C is low. B, his HDL-C is at intermediate, LDL-C is at intermediate risk threshold with additional risk modifiers. C, he has diabetes and meets high risk criteria. And D, his BMI is over 28. Does anyone want to give it a try? Okay, go ahead, Rasha.
I think it's C.
Okay, he has diabetes and meets high risk criteria. Anyone else wants to give it a go? Okay, so actually, Rasha, you are correct. According to Diabetes Canada, diabetes is considered high risk for anyone with a history of cardiovascular disease. So it is C, even though when you look at the other answers, they are also risky, let's say, modifiers. So when HDL-C is low, we need to tackle that. So we always encourage omega and other, let's see, dietary supplements that can help push it up. With LDL-C, we have to look at that as well because we know it is higher than we want it to. So that with a statin is also covered. His BMI is over 28, so we have to encourage the idea of diet and exercise in order to bring it down to below 25, okay? But with this, the primary reason for starting a statin would be his diabetes profile, okay? Moving to the next question, what is the LDL-C target for Mr. Carter? And that's something MCQ students are actually asked about. EE, not so much, like they usually give you a reference, but with MCQ, they do look at this. So what do you guys think? Any answers? Okay, so I'm just going to jump in over here. With LDL-C target, it's usually less than 1.8 millimole per liter for Mr. Carter's case, given his overall risk factors.